right, today we're going to talk about the large intestine positioning. And with the large intestine positioning, you need to make sure that the patient is completely prepped. So what that means is the patient needs to do some kind of bowel cleansing. They need to clean out all the fecal matter within their intestines because that fecal matter can look like cancer or masses within the colon. So we have to do extra views to prove that it is or is not masses and just stools. So it's really important that the patient's prepped. Some of the limitations for a patient on doing the prep correctly is severe diarrhea. If they have any kind of gross bleeding or obstruction of the large colon, we're not going to prep those patients. So there's different bowel cleansing methods. There's the complete intestinal cleanse kits that you buy at the drugstore. That's usually we'll recommend that, or some kind of cleansing enema to follow. Typically we do the complete intestinal cleansing kit along with the cleansing enema at the end. So disposable plastic enema tips are what we use with the bags, and typically they come as a kit. And everything's disposable, thank God. Smaller enema tips are necessary for patients with strictures or fissures, inflated hemorrhoids, or any other kind of anal abnormalities such as surgery or anything like that. We need to use a smaller tip. A lot of times we'll go to a feeding tube if that's the case. So retention tips have a balloon cuff at the end. So we inflate the balloon, usually under fluoro. If your doctor trusts you, they'll let you do it beforehand. There's a certain feel to when you're blowing it up that is really critical that you know what that feel is. Otherwise, you need to blow it up under fluoro with the radiologist there because you can perforate the colon. So here's the thing, you blow it up under fluoroscopy, and if we're going to use if we're going to be doing a double contrast barium enema, there's a certain tip that we use, the one that has a thing for air, like it's a blue bulb, and then there's one that has the sponge filled plastic for the balloon, so it has two tubes coming off it. A single contrast only has one tube coming off it, so you need to make sure that you're grabbing the right tip for the study that you're doing. Barium enema bags hold 3 quarts or 300 milliliters, and they have a filter to prevent passage of unmixed lumps of barium. The tubing is about 6 feet long, and there's a clamp on there to help you control the flow of the barium. A lot of times I'll just grab the tube and stop the flow with the tube because sometimes the clip gets under the patient and it's hard to maintain that. So make sure when you actually put the clip on that you drain out the barium, so drain the barium so there's not a bunch of air in the tube, and then you clip it up high so that you can find that clip really easy. Otherwise, just clamp it with your hand. The small bags, they're 500 milliliters, and they're large diameter tubes for the double contrast procedures. So high density barium is used. The temperature of the suspension should be lower than the body temperature. You don't want hot barium going into the patient. It can burn the really sensitive lining of the colon, so you need to be careful. Don't give them cold water because it's going to cause the colon to spasm, so just use lukewarm water is usually the best. Patients tolerate that really well. So getting your patient to cooperate with you is key. You've got to make sure that they understand what we're going to be doing. So you need to explain exactly what's going to happen through the exam. You need to explain that it's uncomfortable and that they're going to feel like they need to go to the bathroom really bad. If they need you to slow down, just have them tell you, you know what, give me just a minute, hold on, just while they get through a spasm. Really important you tell them to relax their abdomen. Deep oral breathing, so they call that yoga breathing. So deep, slow breathing. You don't want them because they're going to hyperventilate and then they're going to pass out on you. They get lightheaded really fast. Communicate cramping so that the filling may be slowed or stopped. That's what I was talking about. Is grab the tube and stop it and hold it until the cramping passes. It's essential to talk to the patient about their fears. This is a very scary and embarrassing procedure. I've done so many of them, it's second nature, and I forget that this is very embarrassing for the patient. So make sure that you talk to them about not pushing and holding that balloon in there, and ask them to answer any questions to the radiologist, and the radiologist will be in the room during the procedure and can answer any questions that they have. So also make sure that your patient is covered up. There's nothing worse than the patient being fully exposed, and in this procedure that we're doing, they cannot have any underpants on. So it's an exam that's very embarrassing for the patients. All right, so be aware, the patients, if they're a little old lady or a little old man and they did our prep, the prep is very, very exhausting, and it messes with the patient's salt. Okay, so we've dehydrated the patients. So we've taken all the water and it went into the large bowel to push out all the fecal matter. So their salt is screwed up, they're dehydrated. So you have to be really careful, because the weak and the elderly are going to be even worse. So don't let go of that patient when you stand the table up. Make sure you have one hand on that patient at all times. I've caught a lot of people, so you need to make sure you're there and make sure that they're not going to fall. When you get the patient up to use the restroom so that they can clean out their colon for your Postevac, you need to make sure that you walk with the patient. Before the exam even starts, you should put like a stack of towels, a couple washcloths. I run the water so it's warm for them so they can clean up. So I walk them to the bathroom. I show them where the emergency button is, and I check on them all the time. Every couple minutes, are you okay in there? Are you okay in there? I've had patients pass out while they're in the bathroom. So you need to be aware that they are definitely fatigued by the end of the exam, and they get lightheaded and diaphoretic, and they will pass out on you. Okay. So, light evening meal prior to the exam. Typically, we don't do that. We like them to be NPO for 24 hours. They're going to do a bowel cleansing kit, NPO for sure after midnight. No chewing gum, no smoking, and the enema the morning before the exam to make sure that they're nice and cleaned out. So, floor room setup. So you're going to put the table flat. You're going to make sure you have your IR cassettes available if you're not digital. And you're going to make sure your barium is hanging. You can see it hanging here. I usually hook the tube on the little hook right here, so that, or up top, so that it is off the table. I don't like it on the table. Make sure you have clean towels and clean linen available. On the table, I usually tape the pad top and bottom onto the table, but you need to be able to change that very fast. So sometimes I'll use chucks. I'll put chucks under so that I can just change the chuck instead of all the table linens. Okay, so for single use, it's a closed system. You can see here it comes pre-powdered barium, and you just put water in it in the hole there, and you shake, 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 shake. Make sure you clamp it before you put the water in, or else you're going to have barium all over the floor. I don't like these tips. I'll cut the tube and I'll put a flexible tip on there. This is a hard plastic tip, and it's just not comfortable for the patient rolling around on the table, and I'm always afraid I'm going to perforate the bowel, so I don't use these tips. I always cut that off and use a regular, or I just use a air contrast BE kit, and I tie off the air hose so the doctor knows it's a single contrast. I don't use cold water. I use lukewarm water. That is the best. Do not use hot water. That's the main point there. And you're going to make sure that the suspension's mixed up well. You can use glucagon if the patient has a lot of spasming during the exam. You can have the nurse come in and give glucagon, or you can have it available for the doctor if they like. And you can mix topical anesthetics with the contrast. I don't do that. They don't need it. Here is a single contrast enema tip. So you can see tip here, nice soft flexible tip. That's not what was on the other one. And here's a hose. This is the sponge within the plastic, and it has a little clip here. So make sure it's inflated like this. So what I do, once I insert the tip into the patient, typically I'm allowed to blow up the enema tip. So I'll blow up the balloon, and I'll clamp it with the clamp, and then I'll take, there's a little slot thing here, and you can slide this off, fill it up again, and then I put it back on. So if this clamp doesn't hold, which it doesn't a lot of the time, it'll go, I'll see this thing growing and blowing up like it's gonna explode, and it's real easy to put the air back into the balloon. So I'm ready. Or in case the patient starts to leak and I can see that I still have room, I can blow up the balloon further. So this is what is typically on the single contrast barium enema tips, and they're hard plastic, they're terrible, don't use them. This is a single contrast. As you can see, we have the one air tube for the balloon here. So this is how you blow up the balloon. You put that little square sponge on, the square sponge, and it slips right on the end, and you can blow that up. And then you can see here, this is the double contrast, so you can see your air tube here, and then you can see your air hose for introducing the air into the colon. Excuse me. So your barium's going to flow through. You have your air for your air hose and your air to fill for the double contrast. And this is what the balloons look like inflated. Okay, so there's also a colostomy kit that you can use, and you can slide your tip right in through there. I usually use a feeding tube and blow up the balloon and hook it in there. So that's lots of fun. All right, so when you're putting the tip in, so you instruct the patient to turn onto the left side. We're going to put him in the Sims position. So Sims position. So roll the patient forward 35 to 40 degrees and rest the flexed right knee above and in front of the left knee. So here they're lying on their left side, and here's their left leg. You're going to take this right leg and you're going to bring it up and over. So that's going to expose the anus for you perfectly. And it puts the colon in a position where it's really easy to get that tip in there. So relax the abdominal muscles, so it decreases the abdominal pressure, and it aids in relaxation of the sphincter. So you're going to take the IV pole, so the bag is no higher than 24 inches above the level of the anus, and you're going to expose the anal region only. You're going to run the barium into a basin to remove the air from the tubing, because you don't want to induce, 6 feet of air into the patient before you even get the barium going in there. It can cause a vapor lock, what we call vapor lock, where the air locks and you can't get the barium in. So that's no fun. You're going to use KY jelly, and you're going to put it all over the tip. You're going to tell the patient, I just put KY on here. It's going to be cold and slippery, okay? And I tell the patient, taking a deep breath, blow it all the way out as I go ahead and insert the tip nice and slow. So you're going to wear gloves. Make sure you talk to the patient, and insert the tip slowly, steadily, and gently during expiration. Direct it anteriorly 1 to 1.5 inches, then slightly upwards, so superiorly. The distance is no more than 4 inches, and the tube's only like 6 inches long, so as you know, you're not going to put the whole thing in there. Never, never, never force it into the through the anus. A lot of patients have stuff going on down in their anus and their rectum, and it's really careful that you don't perforate anything. So if the patient's really having a hard time, you can ask the patient to assist you in getting that tube in. Don't be shy in asking, because sometimes they'll do it and they don't want you to do it. So better for us, right? So here you can see you're going to put the tip anteriorly, and then you're going to go superiorly, and it's going to sit right in here. You're going to blow up the balloon. It's going to sit right in there. If you go too far, you're going to be hitting up in the sigmoid area. You don't want to do that, so you want to rest right in this area. This is what the patient's going to look like. You have your tube hanging. You're ready to go. You have the air right there, so this is a double contrast, and you bring the tower over, and you're ready to go. So after the tip is inserted, hold in place while the patient turns supine or prone. You can blow up the balloon once the radiologist gets there, and you're going to make sure the tube is free from the patient laying on it so that the barium will flow. A lot of times the patients will be laying on the tubing, or it's kinked and barium's not flowing and the doctor can't figure out why. Check your tubing and make sure that they're not laying on it. So this is a closed system. This gives you an idea. We use gravity to fill the colon. So we're going to bring the bag up, we're going to open it up, and it's going to free flow into the colon. And then when the doctor says, okay, that's enough, go ahead and drop the bag. You're going to bring the bag down so that it flows back out, okay? We don't want too much barium in there. You can use a method like this where you can go ahead and turn the bag upside down and push the air in. I don't particularly like this method. I actually prefer the blue bulb and just until I'm happy with the amount of air that's within the colon. But we control how much barium is going into the patient by gravity. So single contrast barium enema. So you introduce the patient to the radiologist, and when they say so, you can go ahead and release the clip to allow the barium to flow. We stop the flow of barium to reduce cramping, and the instinct that patients have to defecate. So make sure you tell them nice, slow breathing. And then the doctor will take images, or she will take images under fluoro, and they may stand the patient up again. So you need to be, that's on a double contrast, never mind. So single, they don't do that. The radiologist will take a bunch of images and ask you to take overheads if needed. Okay, so you'll take out the enema tip. Make sure you take the balloon off first. So you got to take that square sponge off, open the clamp, let it open up. I usually have the trash can right there, so I put the bag, because it's 6 feet long, the hose, so I'll put the bag in the trash can in the biohazard, and then I'll release the balloon. I'll take the sponge thing off and release it, and then grab a towel or a paper towel or whatever, and I'll pull it out of the patient and just drop it right into the trash can. So make sure you assist the patient to the restroom and instruct to expel as much barium as possible. The really weak patients, you're gonna have to get a bedpan. That's the only way to do it. Just know it's all barium. Rarely that there's stool in there unless you're doing gastrographin. That's a totally different story. So after the patient has evacuated, you're going to do one more KUB to check the mucosa and see how well they evacuated. If they didn't evacuate well, you can give them a hot drink if the radiologist says it's okay. Usually I'll just put them back in the bathroom and have them go again and put them back on the table and take the image again. So here is a picture of a single contrast. You can see the ileocecal valve here. It's not holding, so you can see it backflowed into the small bowel, so you almost get a full small bowel. You can see the balloon right here. This is the balloon. So good location. The one thing about this, look at how different the haustra is compared to over here. So this tells me this patient has some kind of ulcerative colitis, lead pipe syndrome right there. It's interesting. Okay, so the double contrast, there's two different types. There's a closed system and the Whelan method. I've never done the Whelan method. It does look really good, but I've never done it. So the closed system does not require removal and reinsertion of the enema tip. I just can't even imagine doing that to a patient. But I'll show it to you, and I'll show you how it looks different. It looks really good. So we use the Whelan method to look for small lesions, and it does show them really well. But I can't imagine we'd miss these on just a normal double contrast barium enema. All right, for a single stage closed system method, the barium is introduced and removed via the bag position, just like I showed you in that one slide. Air is introduced by bag inversion or manual compression of the sphygomanometer bulb. I'm sure I said that wrong. So the blue bulb. All right, for the Whelan method, so the barium's introduced to the left colonic flexure, then the tip is removed. The patient goes to the bathroom, the tip is reinserted, and barium is introduced to the sigmoid only, and air is instilled. So the patient positions altered to coat the mucosa. And we do the same thing with the double contrast. We have the patient roll in different positions, moving the barium in the air where we want it. So the doctor is going to take spot radiographs as needed. So you can see here, this is the Whelan method, and it's really good for the mucosa. You can see the mucosa really well here, unlike the double contrast traditional method. Okay, so, sorry, I jumped out of place. Here, we are looking at your positions for the barium enema series. We have your PA and AP. There's a sigmoid that we're going to do, but the sigmoid, we're actually going to kind of bring it down here, so I'm going to jump over it. You have the REO, LAO, LPO, RPO, right lateral rectum, right and left lateral decube, and you're only going to do those decubes if you're doing double contrast. You have a cross-table lateral rectum and a Postevac, so it can be AP or PA. Typically it's PA. Your special views are your AP axial or PA axial oblique. Looking here, we have your positions that are from your Merrill's. This is from Bouchon, and it's streamlined. So here's the same views, just so you know, they're here. The radiologist is going to typically do your upright views for you. They're going to do AP or PA. They're going to do some obliques. They're going to do a lateral. So they do these for you typically. And going right into your PA or your AP. Depending on your radiologist, you need to talk to them and find out what the protocol is. But you're going to do, of course, AP or supine, or prone or supine, and you're going to line up to your MSP, which is your mid-sagittal plane. You're going to center to the iliac crest, so you're going to be perpendicular, so no angle, and like I said, at the iliac crest. So this one we're going to cover a little bit further down. So here is your PA right at the iliac crest, and make sure you line up your bucky. And this is what it looks like. And here too, this is a double contrast, whereas this one's single contrast. So single contrast, you don't see any air within the colon, where here you can see the air mixed with the barium. So you can see here, this is a traditional method, just the double contrast, and the Weiland method, you can see the lining a lot better. Okay, so PO oblique, so we're talking about the REO or the LAO. We're going to rotate the patient 35 to 45 degrees. So the REO best demonstrates the right colonic flexure, ascending colon, and sigmoid, where the LAO best demonstrates the left colonic flexure and the descending colon. And with your PA oblique, so part position, so supported by the flexed knee and the arm of the elevated side. You're going to go to MSP. Your IR is centered at the iliac crest. So the CR is coming in perpendicular, and it enters 1 to 2 inches lateral to the midline of the body on the elevated side. So you're going to go 1 to 2 inches from MSP toward the elevated side at the level of the iliac crest. And the picture shows it on the other side a little bit better, so it's hard to see on this one. So this is your REO. And you can see here, beautiful, oh beautiful. And then you can see here on the elevated side, you're 1 to 2 inches on the upside. And beauty, beauty, so pretty. All right, so your lateral position, so the patient's recumbent right or left, lateral. Your MCP, mid-coronal plane, is centered. The knees are flexed for stability. Shoulders, hips, and knees are superimposed and perpendicular. So when you center the IR to the ASIS, now I normally bring the elbows together in front of the patient or have the arm down to help hold them into the position so they're not rotated. So MCP at the level of the ASIS. You use a 10 by 12, so that's really important. So you can see here, level of the ASIS, 10 by 12, and make sure that if they have a really big booty, that you don't image all of their booty. You can go ahead and collimate to where the sacrum is, so you'll be able to see the sacrum and feel the sacrum. You're just going to shoot it on a 10 by 12. They put lead back here to help with the scatter, which is nice. A lot of times I'll put a pillow right between the patient's legs in addition. So this is what it looks like. Very important view. Perfect, beautiful. Double contrast. You can see the tip is still in place. Typically we deflate the balloon for this image, so I usually do it last. Okay, so the AP axial, so the patient's supine. You have your MSP aligned, and your IR is centered to 2 inches above the iliac crest. So what they mean by that is a little bit different than what you're thinking. So you're going to angle 30 to 40 degrees cephalad. It's going to enter the patient midline, so MSP, at the inferior margin of the pubic symphysis. Okay, so the top of the IR, where they talk about here, IR centered to 2 inches above the iliac crest, so that is not centered. The top of the cassette is 2 inches above the iliac crest, so it's kind of confusing how they worded that. So 30 to 40 degrees cephalad, mid-sagittal plane to enter the inferior margin of the pubic symphysis. And I don't usually use a 14 by 17. If you have an 11 by, you're going to use an 11 by. You can even use a 10. 10's kind of small, but at least collimate down. So here is the pubic symphysis, and you're going to be entering right at the pubic symphysis, and 30 to 40 degrees. I usually just go right at 35, compromise. One place I worked at said 37 degrees. Okay, so we're just looking at the sigmoid colon here. Make sure you line up your bucky tray so that you are not clipping. And this is your image here, so we're looking at the sigmoid colon right here. So this is it. And this is your double contrast so that we can see the sigmoid really well. So as you can see, we don't need a full 14 by 17. You can get it on a smaller cassette because all you need is just this area. That's it. Okay, so the AP oblique. So this is 35 to 45 degree angle of the patient, so LPO or RPO. So LPO demonstrates the right colonic flexure and the ascending and the sigmoid. The RPO demonstrates the left flexure and descending. So opposite of, so RPO left, LPO right. Different ways to remember it, whatever works for you. So MSP, you're going to use a sponge to support the elevated side. You're going to use the dependent knee. It's going to be flexed to help support the patient so that they don't fall. And the IR is centered to the iliac crest. So CR is perpendicular, enters 1 to 2 inches lateral to the midline of the MSP on the elevated side at the level of the iliac crest. Same thing as the PA obliques, same thing. So here you go. So it's 1.5 to 2 inches from MSP. That looks more like an inch. And here's your image and double contrast. So this is your right or left lateral decubitus. We only do these on double contrast. You don't do them on single contrast. So air or up is site of interest. Okay, so the right lateral decube position demonstrates the medial side of the ascending colon and the left side of the descending colon. The left lateral decubitus demonstrates, the lateral side of the ascending colon and the medial side of the descending colon. Excuse me. Okay, so patient is in the recumbent lateral, so the back or the abdomen is in contact with the grid. Did you hear that? Grid. So what that means is you need to have a portable grid and a CR plate. The body is elevated on a radiolucent sponge to support the center of the MSP to the midline of the grid, and the IR is entering at the level of the iliac crest. So horizontal beam, make sure you're not angled, else you're going to have grid cutoff, and you're going to be centered at the iliac crest. If they have a really high flexure, you're going to want to sneak it up. Okay, so here you are at the iliac crest. You can use the wall bucky or you can use a portable cassette and grid. I find the portable cassette and grid is the fastest. That way you don't have to get the patient off the fluoro table. So here you just roll them up, shoot, roll them up the other way, and shoot. And this is what it looks like here. So you can see the left side up, and you can see it's nice for that. And left side up with a better air contrast, very redundant bow. And then you can see here, this is your left lateral decube, and you see the right side really well. All right. So your Postevac, after you've done your decubes, sometimes they want a cross-table lateral rectum. You have to find out, and that would be in the prone position, and you'd shoot straight across here. So you'd have a cassette with a grid. It's a 10 by 12, and you shoot straight across. That's a view that the doctors may require. All right, so after the patient uses the restroom, you're going to do a Postevac. You're going to lay the patient down prone for your PA, and make sure you get all the colon. Don't clip it. So the other exam is called a Defecogram. So I know you guys at Kaiser do these regularly, which is amazing. I've done 2 in my life, and I've been in for, gosh, we're pushing 20 years now. So Defecogram, so what happens is it's an exam where we look at the anus and the rectum while the patient actually defecates. Very interesting. So we look for rectoceles, rectal intussusception, or prolapse of the rectum. So the patient sits on this little chair thing. So we have it up against the fluoro table. And if it's not high enough, you have to get it so it's high enough, which makes it a lot of fun. So this is where the patient sits, and we fluoro and watch them defecate. So we will go ahead and inject in contrast. So there's a hose here, you can see that. We put it into the patient. You can use a syringe type, and it's like a caulking gun, and insert this into the patient's rectum, and then have them go ahead and strain and see what happens. So here's the straining or evacuation, and here's your post-evac images. So that's your positioning of your large colon. Lots of fun. So make sure you pay attention and you understand the views. Talk to Jeremy. Email me if you have any questions.